Thanks for having us.
Great, and I think you have a poll to start us off. So everybody get ready to use your mice to click on some answers for this polling question. It'll pop up in just a second. So the first question is, so the Indian Health Service, this is a true or false question. Indian Health Service is a healthcare organization operated by Native American, Alaskan Native tribes. True or false? The next question is, have you worked with an Indian Health Service or tribal facility in your area / county? So yes, I have. Yes, currently you are. No, I have not. If everybody could answer those, that would give Marie and David some information on our participants today.
Okay, super. Thank you.
All right, so here we have, so it seems that some of us liked true for the statement that you picked. Some of us felt that it was true that the Indian Health Service is a healthcare organization operated by Native American and Alaskan Native tribes. Some of us, a little bit more of us, felt that that was false, so I'm interested to hear what the real answer is. And then number 2, looks like we have about 35% of us have worked with an Indian Health Service or tribal facility. And then 60% have not, with one currently, I'd say about one currently working with an Indian Health Service or tribal facility. Is that helpful, David and Marie?
Yeah, that's really good, actually, because it shows us that quite a few folks have not worked with Indian Health Service before. So hopefully our presentation will be enlightening on what they do and how we work together.
Great, take it away.
All right, so we really appreciate you guys having us on today. If any of you watched the Epi Roadshow, you'll see the same presentation, except for we're hoping to get to all of our cases at the end here, which I think you guys will find very interesting. Next slide. All right, so neither one of us have any conflicts of interest. Next slide. And we're hoping by the end of this that you'll know how a local health jurisdiction can work with IHS Public Health Nursing to manage tuberculosis on a reservation, and how we do that to improve our treatment completion rates, and also understand some of the unique challenges that you're going to encounter when you do manage TB cases on a reservation, and how we address some of those challenges. Next slide, please.
So I just want to give a little overview of the Yakima Reservation. It covers about over 2,000 square miles, and it's in 2 different counties, primarily in Yakima County. There's a little bit of it in Klickitat County, but there's currently 11,000 enrolled Yakima members right now. And just for some people reference, the Yakima Reservation, not all of it is owned or private. Some of it is private land on the reservation. So you have kind of a mix. It's kind of like a patchwork quilt. So some reservation land next to private land. So that makes things a little more complicated. Next slide.
So why do we even need to collaborate? You know, if we only had a case here or there on the reservation, it probably wouldn't be something that we had to worry about too much. But unfortunately, in Yakima County, as you can see here, the TB rates amongst Native Americans are very high, much higher than pretty much any other racial group in our county. And the majority of those folks do live on the reservation, and that's something that we've had to address really for probably the last 10 to 15 years. Our high rates of TB with our Native American population on the reservation in particular. So if you look at the statistics of Yakima County TB, we actually have about half and half U.S.-born to foreign-born TB cases, unlike most folks in the state and in the country. And about, I think last I looked, about 85% of our U.S.-born cases are Native Americans. So it's a pretty big amount for us here in Yakima County. Next slide, please.
So now I'm just going to go over a little bit of what Indian Health Service is. So to answer the first question is actually false. Indian Health Service is a federal organization housed within the Department of Health and Human Services, and it's run by the federal government. Indian Health Service is, and it started way back in 1787. It's the primary health care provider for Native Americans and Alaska Natives. It serves over 2.5 million people in 37 states across the country, and there's over 170 IHS facilities across the U.S. Next slide. It's located in Toppenish. That's where Yakima Indian Health Service. And in case if you pay attention, we didn't misspell anything. Yakima, the tribe, is with all A's, and the city of Yakima has an I in the middle. So back in the mid-90s, the tribe changed their name to Yakima because they thought it more closely represented the pronunciation of their tribe. So if you see some of the differences, I think the map actually has an I in it, so I think it's an older map. Anyway, that's just a little history on the tribe itself. It's also, Toppenish is also where their headquarter office is, their agency headquarters, which is just down the road from our clinic. And it's also, for reference, across the street from the casino, Legends Casino. Our clinic sees over 13,000 patients. As you remember the previous slide, there's 11,000 enrolled members, so we see everybody, not just Yakima. Indian Health Service does. We offer primary care, optometry, dental, radiology, kind of cover everything for primary care. So to make it confusing, there's a difference between Indian Health Service and the tribe-run programs or clinics. You can have an Indian Health Service clinic that's completely run by IHS, by the federal government, and then you can have tribal clinics that is run by the tribe themselves. So they still kind of come from the federal government, from IHS itself, but the money is just kind of allocated differently. So whether it's decided by Indian Health Service, how it's staffed and run versus how the tribe staffs and runs it themselves. And to make it more confusing, within IHS, you can have both together. You have some programs are IHS and some that are tribal. So it's a whole nother layer of confusion. But there's also a small satellite clinic out in White Swan, which is about 20 miles west of Toppenish, and it's a tribal clinic built by grant money out there to serve their population. IHS will come in and do services that they don't have. So I do a women's health clinic out there. We'll do well child clinics out there. It's whatever services that we work with them on. So next slide.
So when we do have an active TB case that is a Native American, lives on the reservation, the IHS Public Health is actually the ones that are kind of the point folks on that. They take on primary responsibility for that patient, making sure that they get the case management that they need, just like we do through the health district. They actually have a doctor, Dr. Cruzy, who has lots and lots of years of experience treating active TB cases. So he sees primarily all of the patients. And so what is it that the health district does is the question, right? So what we do is we offer consultation, whether that's medical consultation for those medically complicated cases. We also offer nurse case management consultation. So Marie and I and Marie's predecessor and I always worked closely together, phone, email, in person, so that we could offer assistance when needed on how to manage certain social issues or legal issues or medication issues. We also help with contact investigations. So as you can imagine, when you have somebody that lives on the reservation, it doesn't necessarily mean all the people they hang around with are only Native Americans on the reservation. So there's going to be contacts off the reservation that we're going to help with. If the contact investigation is very large, then we can offer assistance on the reservation also to do testing and find the contacts. And then if we have a non-adherent patient, the health officer can be involved. That's definitely more complicated with the Native American on the reservation, which we'll talk about in our cases. And then training for clinic staff. So the public health staff in general, are well trained in the same kind of things that we're trained in as far as contact investigations and case management of TB cases. But the clinical staff doesn't necessarily go through that same training and see those folks as often. So we can provide training for the medical staff and the nursing staff there, so they better understand, how to manage the cases when they come in for their clinical evaluations and TB testing and all of that kind of thing. All right, next slide.
Yep, so I do a lot of all the case management for the TB patients, and I do the contact investigation. So I will go wherever my patients are. It does not matter to me if they're on or off the reservation, I will go to them within reason. I also coordinate all the care within our clinic. So if they need to come in for follow-up, if we're ruling out active TB, I coordinate all that care within our clinic. And then I keep David updated on all the situations as they go. So if I'm treating an active case, he's up to date on how that's going, if they're compliant, that sort of thing. So currently I'm a staff of 1 in my department, so heaven forbid I get hit by a bus or something, David is at least up to date on what's going on with the case. He knows where I keep the meds, he knows I keep a log, so in case he needs to know, what happened yesterday, it's all in there. So and for large cases, like a current one I just had, we worked together on, so.
And one of the things that I did forget to mention is, which you guys would probably be interested in, is all the data that goes into WDRS. That's also something that I take responsibility of making sure that all gets in there, because Marie doesn't have access to that. So Marie does a great job of kind of getting all that information tallied up for me and getting it to me, and then I'm able to enter all that into WDRS as far as the contacts and the case. So that's something else that we make sure gets done. All right, next slide.
So this is a typical day in the public health nursing at IHS. This is from a contact investigation. Sometimes you don't always get really good information initially. Sometimes we can't interview the patient, the active case, so either because they're too sick or they passed away, so sometimes you only get bits of information. So the slide on the left is one of the names I had, and this is the only contact information I had. All the phone numbers didn't work, and that's the only address that was boarded up. The slide on the right was the second name on the list that was a nickname. So that was me trying to drive to the house, which was flooded out. And so I learned, used my community resources and found a back way to the house. And lo and behold, they didn't know the patient didn't live there, but they knew who the patient was and gave me not an address, but a make and model of a vehicle that was maybe parked on this road. So I drove down the road and found the vehicle, happened to be home and parked in the front, and found the home, and I had a bunch of kids and got them everyone tested, and it worked out, but sometimes it's kind of a scavenger hunt. So next slide.
So one of the things that we do run into from time to time, and we'll go into more detail on this with our first case, but non-adherent patients who are infectious, how do we kind of manage that? And typically when a person's off reservation, it's a lot smoother process. I think pretty much this audience knows kind of how that all works, health officer directive. After you've tried everything else, and if that doesn't work, you can always petition the court and go from there. Well, when you have non-adherent patients that are on the reservation or Native Americans, you have to figure out who has jurisdiction. Is that even an enforceable public health directive? How do you enforce it? That can be very complicated. And then when do you involve tribal authorities? So that's something that we don't deal with a lot, but we do deal with it from time to time, and it can be very challenging. Next slide. So a few other obstacles that we just kind of were thinking of that we run into, fairly commonly on the reservation. And some of these we'll talk about in our cases, but again, just IHS versus tribal, safety concerns for the nurses. Sometimes we're dealing with situations where there's substance abuse issues, domestic violence issues. Sometimes Marie has to get CPS involved. The tribe actually has their own child protective services. And so working through that process, and, obviously families can get very upset, that you've done that. And then, like she said, she's only got herself. So staffing has been a big issue for her the last really couple of years, I think. So definitely some challenges there.
Yep.
Next slide, please. All right, so our first case, this one is a good example of how challenging it can be to actually enforce a health officer directive on the reservation. So this was a case we had a few years back that we're calling Prince Edward, but 20-year-old Native American male. He was living on the reservation, although he was like right up against a city that is in the reservation, but the city itself is not technically the reservation. So he was living there. He was a known contact to a couple of active cases. So he was somebody that we had been trying to find as part of our contact investigation back then, where we had a cluster of, I think up at that point, we had 3 or 4 known active cases, and he had been exposed to at least a couple of them. And so we'd been trying to find him for quite some time, and we couldn't find him. And then he actually was arrested and ended up in the tribal jail. And the IHS public health nurses actually go to the tribal jail and offer some services there. And they saw that he was there, and so they said, "Great, let's get an X-ray and test this guy." So they did that, and X-ray showed upper lobe lesion, definitely concerning for active TB. So they told the tribal jail staff that, hey, we think this guy is suspicious for TB. And of course, they promptly sent him packing. So then they had to go find him in the community. And so luckily they were able to find him fairly quickly. But he did submit to doing the initial sputum samples, and they were all negative, which is good. But he had a pretty long history of smoking methamphetamine for several years. He had either some drug-induced mental health issues or mental health issues. Otherwise, we're not 100% sure, but definitely some mental health problems and drug abuse problems. And he really just refused to do any treatment, to do any isolation. He just wasn't having it. And so that's when, IHS contacted the Yakima Health District, said, hey, can you guys do something? Like, this guy's just not cooperating. And so we ended up doing a health officer directive at that point. And of course, when I went and presented the health officer directive to him, he basically just told me to get lost. He wasn't doing any of it in much more colorful language than that. And so that's when we had to go and, to the Superior Court and petition them. They did issue a warrant for him. So we took it to the sheriff department and said, hey, we got this warrant for this man. And they said, we can't serve this warrant. You know, he's a Native American. He's on the reservation. We have no authority to go and pick him up. So then the next question was, what do we got to do to get this dealt with? Well, you got to go to the tribal court. So first, you got to find a lawyer that can actually practice in the tribal court, because not every lawyer can. Then you got to get on the docket. And so, long story short, it took 4 months for us to actually get that warrant served and get him picked up and get him into forced isolation. And by that time, he was cavitary with 3+ AFP smears, and he had been spending all those months in and out of all kinds of residences, drug houses that we had already been through before as part of the previous contact investigation. So really, really unfortunate how that worked out. Eventually, we did get him through his treatment and non-infectious, but the contact investigation was quite large and quite incomplete, you know, by the time we were done, just because of the population that we were dealing with, lots of substance abuse, and folks just not wanting to give us much information. So that is something that we continually are trying to work on to get that process more streamlined with the tribe, so that it doesn't take so long to get these things enforced. Next slide.
So Princess Elsa, all these are totally made up names. They're not even remotely close to the patient's name. She's a 3-year-old who presented to the ER with seizure-like activity, and then flown to Seattle, where they did further testing, CAT scan, MRI, and blood tests, and just determined to have disseminated TB. It was everywhere. It was in her brain, lymph nodes, lungs, liver, kidneys, eyes. It was everywhere. She ended up with the VP shunt, and then we gave her, all her TB treatment was down an NG tube. Not because she couldn't take anything orally, she just refused. It was really, really difficult to get the meds in her. I mean, you just kind of touched the tip of the NG tube and she was like full out tantrum. So even trying to give them orally, we've of course tried, it didn't work. So this case was quite complicated just for social issues, a lot of substance abuse in the home, domestic violence and mental health issues with some other family members. The neighborhood itself is not a very good neighborhood. It's known for drug and gang activity. So at the beginning of this case, we would go out together just to, you know, establish rapport and who we are, and safety and kind of numbers. So until we kind of developed that, and then, you know, everything kind of calmed down. But this case kind of would peak and valley, kind of up and down, have issues throughout. But, you know, we did treat her for 12 months, daily DOT, Monday through Friday. So, but at times it was really difficult to get mom to adhere to just get her to follow up. Despite all of my efforts working with her and getting her connected to resources and building that rapport, it would just, you know, mom had her own issues. So eventually I did have to involve CPS on this one just because of follow-up. So, but happily she's treated and doing well. So. Yeah,
and this was definitely one where we worked together on just being able to cover for DOTs. And like Marie said, you know, there was times where mom would get kind of hostile. So we would go together during those times just to make sure everything was safe and kind of keep her calmed down. And then, you know, the CPS involvement really was after lots and lots of chances of not having to go down that road. But that was something that we were always talking about, like when's the best time to do that. And so we worked together pretty closely on that case. And luckily it turned out okay in the end.
Yeah, and mom was aware. She knew, you know, despite that, you know, I said, you really need to make these appointments. If you don't, I have no choice. And so, and she was aware of it. And so, but, you know, I used it as the last resort. And I, you know, worked with her extensively to prevent that from happening. But sometimes you have to do what you have to do. Next case, slide. So this next one, she's a 37-year-old who She, in the past, had been treated for LTBI, 4 months of rifampin, self-administered, obviously. And she ended up, she was working up to 2 days prior to going to the hospital, where she was diagnosed with TB and had 4+ smears and had, I think there's 17 household contacts on this. That's also pretty common on the reservation. Does not shock me in the least to have that many people contacts in a household. It doesn't necessarily mean they're there the whole time. You get a lot of transient people that come and go. Some just visit for the weekends, but do it often enough or are there long enough to warrant testing. You just, a lot of homes are, you know, couch surfing, or family comes to stay for a month. That's pretty typical too.
People are staying in tents around the house.
Yeah, so that's pretty common for these contact investigations. And with this one, because she worked prior, so close to being diagnosed and being so infectious, we decided to treat or test everyone at her place of employment, and that was 26 employees. So, and they're a mix of Native Americans and non, so David helped out with those. And then obviously with contact investigations, you have to test them initially, and then you do it again 8 to 10 weeks later. So that was, you know, also very time consuming, and hunting everyone down again because people are transient, they move, their phone numbers are disconnected. Getting them back in just 2 to 3 days later to have the PPD read is challenging. So we try and do quant golds, but sometimes PPD is what works. So, and really
to kind of start this one off, you know, this patient was very critical when she was diagnosed. She really couldn't give us much information. She eventually did die, unfortunately. So really we were already kind of had it stacked against us from the beginning, and then on top of it, all the things that Marie's describing. So it was very challenging contact investigation. But again, it was something that we were always communicating about, you know, we were working on together.
Yeah.
I was, you know, trying to handle the off-reservation non-native folks, and she was handling the Native American folks that were on the reservation. We did some of the employment screening. I think we had like 25, 26 people that we had to test at her employer. So we did some of that together because that was a large amount to try to do with one person.
And I did try, you try to interview the patient. I think I attempted to talk to her while she could still talk to us, but she was pretty weak, and it was, I couldn't get any information. So a lot of it was from family that lived in the home. So with this case I've so far gotten 3 positives for 2 positive latent TB, and I treated them with 3-HP DOT, and then I'm finishing up the 3rd one. He has a history of positive PPD in the past, was treated for 5 to 6 months of INH. It was paper chart, hard to kind of read. So we opted to treat him again because of his super high risk. She was so infectious and just super high risk close contact that we decided to treat him again, and he was game for it. So I'm doing great. I'm literally have 2 weeks left for him. And then the other case, the 3-year-old, I treated 5 latent TB out of that household. All what I've done so far has been the 3-HP DOT treatment. It's going great. So I love that treatment.
Yeah, and the prior case, the 3-year-old, obviously we weren't really doing a contact investigation. In the traditional sense, we were really more doing we started with a source case investigation that led to kind of an additional contact investigation from a previous case that we figured was the source. So complicated for sure. Next slide. So future things that we want to collaborate on and work on, and that we're always continuing to work on, is continuing to improve our relationships with not only with each other and our agencies, but also with the tribal authority. And you know, that's probably the one that's the hardest. And we're always trying to make that relationship better. and also continue to identify and focus on the folks that are the highest risk within our Native American population. Obviously, it'd be great if we could just screen everybody, but that's probably not feasible. But we do have one advantage in that a lot of folks go to IHS for their healthcare because they can almost get all of their needs met there from a primary care standpoint. So as those folks come in, we can certainly screen them and get them tested. So that's something that we're, really working on, is trying to have a better focused TB screening program at the IHS clinic to try to catch a lot of these folks that we know have been exposed over the last 5 to 10 years. Because like I said before, we've had several cases that we just know we didn't get all of the contacts. So a good way to try to get some of those folks and get them tested and treated for their LTBI.
And also, I want to continue to work with the tribal authorities and the agency to get more of a protocol in place, or if you want to call it that, for future patients that are not adherent. That the process will hopefully go a little faster, a little better. Those don't happen very often, but if they do, I'd like to have something a little bit better and more in place. Just like IHS staffing changes, people, change positions in offices. So, what someone did before, they aren't there anymore, or didn't know. So it makes it complicated, but we're certainly, our plans are to, make that, improve that relationship and make it smoother and faster. So, and these are just, we don't want to paint a grim picture of the reservation. These are just extreme cases that are more difficult, that stand out to us. There are some that go pretty normal and are compliant and are great, but these are also, a lot of these issues that come up are pretty common to us, like, just the sheer number of people in a contact investigation and the obstacles we face, that they aren't shocking to us. So, but that's why it's important that we work together and communicate and help each other. So.
Yeah. All right, next slide. Those are our references. And then I think on the next slide is our contact information if you want to talk to us or have questions.
Are any questions now?
Yeah, and that is it.
Great.